This is going to be part 2, or anatomy and physiology of the heart. And this is going to be a quick overview, or talk about the anatomy and physiology that's present or concerning whenever we look at 12-lead EKG. So, first question I generally ask whenever I show this slide is, how many hearts do we have? And most people say, well, we have one. Well, the point is we really have two. We have a left and a right heart. Now, this is the vena cava, or the venous side, and the aorta would be the arterial side, or on the output end. And what we see here is if we're in right heart failure or left heart failure, we get completely different symptomology. So right heart failure tends to spill the fluid into the previous container, and I'm going to kind of try to loop this into one another here. So right heart failure gets us peripheral edema, or the edema starts in the calves and ankles and the lower extremities. We also give, for right heart failure, things like nitro, Lasix, and in some cases we would increase contractile force strength of the heart. Dobutamine would be the ideal drug for this. In left heart failure, we will spill into the previous container as well. Only the previous third space is the lungs. So what that gives us is it gives us pulmonary edema that now compete for alveolar space. So again, how many hearts do we have? Well, we only have one heart, but we treat patients like they have a right heart and a left heart. So keep that in mind. And this is going to come up again whenever we talk about right ventricular infarctions. We treat right ventricular infarctions differently than we do left ventricular infarctions. Questions on this is how many layers do we actually have? Now, when looking at the heart, it has multiple layers. So let's kind of go through these. On the inside, that would be the endocardium. In the middle, this part here, it would be the myocardium. And on the outside, the epicardium. Now, it's covered by a pericardial sac. The pericardial sac has two different layers. It has a parietal and a visceral pericardium, and that depends on the part that's touching the organ or not. The visceral pericardium would be touching the organ. Now, when looking at this, we look at this because we have a STEMI event. A STEMI event is a ST segment elevated myocardial infarction. I'm going to erase here really quick. We come up with some terms. So whenever the 12-lead looks at the heart, it's looking at specific sections of real estate or specific sections of myocardium. If the event is transmural, and what I mean by transmural is full thickness, then what is going to be seen on the 12-lead would be ST segment elevation. So P, Q, R, S, and then we generally get an ST segment. And we'll talk about these waves more, the J point here. But this is what we generally see. Now, if we see a partial wall thickness, or this section here would be affected, we can still see electricity traveling down this myocardium. So if we're looking at that section, what we'll generally see is ST segment depression. So we get two pictures here. Both of them indicate ischemia. Both of them indicate possible infarction. We just need to know what message the heart is telling us whenever we're looking at it. Again, a full thickness is a transmural event. Those are the ones that we see the best and see the most. ST segment elevation is what is going to be shown in a transmural event. Arteries and veins. And the veins are more elastic, the arteries are more elastic, and they actually have an extra section of tunica media, or an elastic membrane in here. So this little section right here is in addition to what is seen inside the actual veins. Now, what that does is it makes them more pliable and more elastic. Capillaries at the level, these are fenestrated. These are one cell layer thick. So this allows for easy movement of oxygen in and out. Nitroglycerin primarily works on the veins and on some arterioles. So what did the coronary arteries resemble? Now, the coronary arteries are protected from high pressure, and we'll talk about that here in just another second. They are the first ones fed, and they're fed by the afterload pressure. Matter of fact, whenever we replace coronary arteries, we replace them with veins. So what that allows us to do is whenever we give the signal or give the chemical signal to dilate, the veins respond, and they are responsive to nitroglycerin. Coronary artery distribution. Now, I want to make this point here really quick. We're going to talk about multiple areas on this. So as the left ventricle increases in pressure, this has a semilunar valve right here. The valve flaps pop open and protect the coronary artery openings during ejection of the blood. At the point that the left ventricle loses its ability or doesn't have enough contraction or enough strength to open up those valves anymore, they're kind of pressure sensitive. So what they're going to do, let me change pin colors here really quick to maybe a blue. What they're going to do is they're going to snap shut. The afterload pressure that remains in the aorta is what's going to perfuse the coronary arteries. Now, if this is running very fast, at 150 times per minute, there's a good chance we're not allowing for appropriate coronary artery filling. Other things. This one right here. This is the left main. This one here, this vessel here, is the anterior descending branch, so it's considered the left anterior descending artery. And this artery right here is considered the circumflex. Now here's my point. If you have an occlusion in this vessel here, you're going to kill 90% of the left side of the heart and 10% of the right. If you have an occlusion here, you're going to kill off 90% of the right side of the heart and 10% of the left. The two areas that they overlap in is this area back here. Now this is very difficult to show on this slide, so kind of bear with me here for a second. This is considered the inferior wall. Now, why it's called the inferior wall is because this area here is this section right here that I just circled is called the inferior wall. Now, why it's called that is because normally the heart, whenever you're sitting upright and looking at the body, the heart does not set up right like this picture is. It's kind of at a tilt. Now, this would be the front of the heart, and this would be the back of the heart, or the anterior posterior portion. This section here switch to blue here so we can see a little bit better. This section here is the anterior portion of the heart, and this section here is the posterior portion, the whole thing. So since the heart sits like so, kind of at an angle, if we look at it anatomically, This would be the superior section, and then the section towards the rear, where the inferior wall lies, would be the inferior section. So that's where they come up with inferior wall. Now, a couple more things before we leave this slide here. The inferior wall is fed by both the left and the right coronary artery. So this section of tissue, this entire spot, is fed by both of them. So if you have an inferior wall presentation on the 12 lead, you cannot tell whether your lesion is anywhere in the left side or is in the right side. You're going to have to differentially diagnose that, and I'm going to show you how in about 2 more slide sets. So, back to this. We have an occlusion here, 90% of the left and 10% of the right. We have an occlusion here, 90% of the left, or 90% of the right and 10% of the left. The area that they overlap is in the inferior wall. Alright, this section right here is called the left main. It also has other names. It can be also called the proximal portion of the left anterior descending artery, since it's pretty much lined up with the LAD. They call it that as well. But this little section right here, before it branches off until the LAD and it branches off into the circumflex, is considered the left main. If you get an occlusion in here or a clot, or to where you're not passing blood supply past that, that is considered the widowmaker. It's going to give you a distinctive pattern, and we'll talk about that as well in the next couple slide sets. The right coronary artery, if you get an occlusion here, everything distal to this point now is oxygen starved. Same way with this. If we had an occlusion here, everything distal to this point. So my point being is, if we have an occlusion in the left main, and we allow that myocardial infarction to complete itself without intervention, essentially what we're going to have here is it killed off 90% of the left side of the heart. Now, you cannot live without your left side of the heart. Very simply, it is what makes cardiac output. The other half of it is, if you have an occlusion here, you can kill off 90% of the right side of the heart as well. Now, can you live without your right ventricle? Well, your ejection fraction, or your overall cardiac output or overall cardiac index, would be affected greatly. Your ejection fraction, if it's supposed to be at above 70% or somewhere around there, or the amount of blood that's ejected out in a cardiac cycle, would go down to about 15 to 20%, which you can live like that, but every time that you roll over in the middle of the night, you're going to have shortness of breath. Blood flow through the heart. Now, this is a quick overview. Best to look in basic EKG to get the idea on this. Blood flow through the heart is 70% of cardiac output occurs during passive filling, so everything's kind of running into the areas that it needs to. At the last of that, the atria contract and give us something called an atrial kick. What that does is that superfills the ventricles. At the point that the node gets here, or the electricity gets here to the apex and it starts traveling into the Purkinje fibers, very simply, contraction starts to occur and pressure starts to build within the ventricles. These valves collapse, closing it off, and the other two valves are pressure sensitive, including the pulmonary and the aortic. The coronary arteries are right here where those stars are to feed the heart first, but during ejection and during pressure, blood is ejected out. The afterload pressure that resides in the aorta is what perfuses the coronary arteries. Left main, LAD, circumflex, down right coronary artery. The atrial kick gives you about 30% of your cardiac output. So cardiac cycle, the heart functions as a unit. Both atria contract and fill the ventricles. This atrial kick is 30% of our cardiac output. The ventricles fill with blood to their limits. Blood is ejected into both the pulmonary and the systemic circulation when contraction in the ventricles occur. The heart gets oxygen blood during diastole. Diastole means relaxation. It means at the point that it is not contracting. So during systole, the heart does not get fed. During diastole, it does. So after it is ejected out into the aorta, the actual afterload pressure, the pressure that's residing in the aorta, is what perfuses the heart. This is a cardiac cycle overview. And what we have here, let me change pin colors so we can see this a little bit better. Sinoatrial node starts, it gives us a P wave. And the P wave indicates the atrial contraction. Hits the AV node, the electricity wave does, and by this time, blood is ejected into the ventricles. The Q wave, traveling down the septum. As it turns and it heads back up towards the base of the heart. This is what gives us the R wave. The S wave is the loss of electricity as the contraction wave goes in this direction in the ventricles. The ST segment. Right here is the spot that is repolarizing, and the T wave hopefully will be repolarizing in the same direction as the QRS did. All of this occurs 60 to 100 times per minute. Cardiac action potential. Now, whenever we take a look at pharmacology, we're going to understand antidysrhythmics or look at antidysrhythmics in classes. So a class 1 antidysrhythmic is a sodium channel blocker. A class 2 is a beta blocker. A class 3 is a potassium channel blocker. And a class 4 is a calcium channel blocker. Now, that's important. In our phases of cardiac cycle, this is what constitute our cardiac meds or our antidysrhythmics that we give in cardiac dysrhythmias. An example. So I'm going to clear this off here really quick. Alright, so let's say that threshold is about right here. Now, how threshold works is as the energy inside of the cell increases and goes up, the closer that we get to zero, the more ready we are to receive stimulus and actually contract. So let's say that we've achieved threshold and are at the peak, and about that time the SA node fires or the AV node fires. At this point, the cellular environment of the muscles would become responsive. That occurs because of the positive ion that rushes into the intercellular compartment and fast channels, and increasingly, very rapidly, increases our action potential energy. At this point, potassium and chloride start coming out. In phase 2, which is really important here as well, we get an influx of calcium. Now that does two things for us. It slows down the reaction a little bit, so it makes the heart have more contractile force strength. It gives it time to kind of contract and contract a little harder. That's the influx of calcium that does that. So that's going to be in phase 2. In phase 3, potassium starts coming back out. Now what that does for us is, for years we thought that, I'll clear the screen again. For years we thought that attacking the sodium channels were the ways to go. So we would attack the sodium channels in this area here, extending phase 4 repolarization. In phase 0 we would adjust the sodium channels. Now what we've learned in latter years is that if we adjust the heart's ability to attain threshold, we don't get enough cardiac output. So essentially it will create at some point a systole for us. What we do know as far as efficacy goes, that if we block the potassium, that we have some gatekeeping control, if you will, over the action potential generation of the heart. Calcium channels, if we block that, decreases contractile force strength. Potassium channels, if we block that, apply some gatekeeping control over the action potential. But we generally do not block the sodium channels or mess with phase 0 or phase 4, because that's our ability to generate electricity in modern medicine. And this has been since 2000, 2005, and the new AHA changes. There are 2 stages of repolarization that we'll talk about here as well. There's the absolute refractory period, and what the absolute refractory period means, the cardiac cells cannot respond to a new electrical stimulus. So whenever we are in the middle of the QRS until we are halfway through the T wave, and what the T wave is the repolarization of the ventricles, we do not have the ability to initiate a contraction. It is absolutely refractory to any outside stimulus. The relative refractory period is halfway through the T wave to the end. So we can get RONT phenomena in this fashion. If we have a big OPVC that gets closer and closer to our T wave, it could generate things like VTAC or VFib. Please, and this is in conclusion, please treat the patient like they have 2 hearts. They have a left heart and a right heart. There are multiple layers of the heart, and the example of this is, I want you to know that a transmural event is full thickness. The vessel structure, the arteries have 1 more layer of elastic membrane. Coronary artery distribution, please be familiar with left main LAD circumflexed in RCA or right coronary artery. In the cardiac cycle, we get 70% from passive filling and 30% from our atrial kick. Cardiac action potentials, please review phase 0, 1, 2, 3, and 4, and what a sodium channel blocker and a potassium channel blocker and a calcium channel blocker might have to do about that. And the refractory periods. The refractory periods, the absolute refractory period is the start of the QRS to halfway through the T wave. The partial refractory period is halfway through the T wave to the end of it. If the stimulus was strong enough in the partial refractory period, it could generate things like VTAC and VFib. References for this section were taken from Professional Paramedic Volume 2, Medical Emergencies, Maternal Health and Pediatrics, Del Mar Learning, Green's 12-lead EKG with Confidence, 2nd edition, and Beasley's Understanding 12-lead EKG, 2nd edition by Pearson. If you have any questions concerning this slide set, please feel free to give me a call. My name is Roy Smith, smithr@SamaritanEMSok.com, or 405-492-8243. Thank you.